Dr. Jason Kellogg. I am the founder and the CEO of Progeny Psychiatric Group. Sure. Another thing where our field is evolving. In 2024, the International Psychogeriatric Association, the IPA, released their definition of what Alzheimer's agitation is, as late as 2024. And it's so important because the word agitation could mean different things to different people. So I talk about how agitation is different than akathisia, which is different than aggravation, which is different than assault, which is different than anger, which is different than aggression. They're all different things and they all have different treatments. As Alzheimer's goes, over 50% of patients with Alzheimer's can get agitated, especially if the Alzheimer's starts affecting not just their hippocampus, but the frontal lobes. The frontal lobes are where we just make decisions, where we balance consequences to our actions. So any disease state, including Alzheimer's, that affects the frontal lobes can start decreasing our ability to think about consequences. And as such, you become much more emotional and much more impulsive. Alzheimer's is already here. We already have 8 million people in the United States with it, but it's expected to double by 2038 unless we find genetic cures for it. And it's not just a United States problem, it's an international problem, some countries even more than us. So it's already a problem and it's going to get worse unless we find cures for it. And it's kind of concerning that sometimes we don't even have the same exact definitions for it, but we're getting on the same page there. And I'm glad that we are. One person's definition of agitation might be different than somebody else's. But when we start having groups like the IPA coming in saying, hey, this is a nice standardized definition that we can all use, I'm happy to implement it and also teach about it. Sure, there's 2 FDA-approved treatments for Alzheimer's agitation. One is antipsychotic, brexpiprazole. It's a partial dopamine agonist. And the other one is Auvelity, which is dextromethorphan and bupropion, which are glutamate antagonists and sigma-1 receptor agonists. Yeah, so when you're treating Alzheimer's, you have to remember these patients can be frail. At the very least, they're usually older, obviously, right? So you have to think about your meds in terms of not only efficacy, but also how rapid the efficacy is. Is it a sustained efficacy? And also big time is tolerability. Because of the age and the comorbidities, they often have other medical conditions. So you want to factor in things like sedation is an important one, right? You don't want to just sedate everybody. If you sedate them, they can have falls, they can have deep vein thrombosis because they sleep too much. They can have worsening of their cognition. Any human being, not just an Alzheimer's patient, if you give them a benzo, they feel sedated, and any of us, if we're sedated, we're going to do worse on cognitive tests. So you don't really want to worsen these folks' cognition. You don't want to worsen their sedation. Patients who are older are very, very prone to tardive dyskinesia. So you have to factor that in. Some folks can get tardive dyskinesia relatively quickly. So when you block dopamine, it makes a lot of sense for schizophrenia, but sometimes for Alzheimer's patients, it doesn't make as much sense. So I'm worried about cognition. I'm worried about sedation. I'm worried about QTC prolongation. I'm worried about EPS. Such as tardive dyskinesia. Yeah, it's tough. I mean, imagine being a caregiver for these folks. First of all, you're spending all your day worrying about them and caring for them and take care of them. And at the end of the day, their agitation usually is directed at you. So you don't even get the thank you for the good job today. You get you become the brunt of their agitation. So sometimes I end up finding mental health care for the caregiver. I try not to do both, right? The patient's my patient, and I can see the exhaustion and the strain in the caregiver, so sometimes I'll refer them to my colleagues. I'll sometimes even initiate a little bit of treatment, but because I'm taking care of their loved one, I try to have them be seen by somebody else because they're often exhausted and tired, and I definitely try to educate them, and I also try to mirror back their strengths and give them some of the kudos that they're not getting from the family member with the Alzheimer's who's just yelling and screaming at them.